Good evening. I'd like to welcome everyone to our virtual discussion on improving outcomes in liver-directed therapies by leveraging innovation. My name is Sarah Lewis. I'm the Director of Interventional Marketing and Business Development for GE in US and Canada. And today we're fortunate to have three experts and thought leaders in the space of liver-directed therapies joining us, and familiar faces to many of you. First, we have Dr. James Ronald, Assistant Professor at Duke University in Durham, North Carolina. Dr. David Madoff at Yale University School of Medicine. He's Vice Chair for Clinical Research and the Section Chief for Interventional Radiology. And Dr. Gordon McLennan, who's currently at the Cleveland Clinic, but in transition to be Section Chief of IR out at the University of Colorado. So thank you, gentlemen, for lending us your time and being with us this evening. They'll be discussing different aspects of liver-directed therapies. They'll share the practical aspects of cone beam CT, advanced applications for liver embolotherapy, and lastly, advanced applications for IR ablations, all in the effort to improve outcomes. A few logistical items before we begin. We'll end our session with an open Q&A, as you can ask questions at any time, and you can do so at the bottom right side of your screen. So we'll be collecting those and fielding them as they come through and have them ready for a live Q&A session at the very end of our session this evening. And lastly, the webinar will be recorded and it will be available in roughly 1 week's time. So you'll get a link to that as well as you've joined this evening. And now I will hand it off without any further ado to Dr. Ronald to discuss his experiences with the practical aspects of cone beam CT for liver tumor embolization.
All right, thanks. I'm excited to be a part of this webinar. My name is James Ronald, and I'm an assistant professor in the Interventional Radiology Division at Duke University. I've been using the GE Discovery for a little over a year now, and I want to highlight some of the practical challenges of doing cone beam CT and how the Discovery has really helped us address these challenges in our practice at Duke. So just as an introduction, I want to say I'm a big believer in the importance of cone beam CT for doing liver tumor embolization. Doing highly selective tumor embolization is going to allow you to be more aggressive with your embolization therapy. For example, in radioembolization cases, this is really going to allow you to drive up your dose to the tumor. And at the same time, being highly selective is going to reduce toxicity. A significant fraction of patients, and some studies say up to half of patients with HCC will die from underlying liver failure rather than their cancer. So it's really important to spare normal liver to the extent possible when you do your treatments. And accurate mapping using cone beam CT is going to help you accomplish both of these goals. So I don't want to belabor these points too much, but I do want to illustrate a couple cases that I really think highlight the importance of cone beam CT. So in our practice, an awful lot of HCCs are diagnosed with screening MRI. And liver MRI has gotten so good, and the inherent tissue contrast of MRI is so good that this really forces us to up our game in IR. So here's a patient with an obvious hyperenhancing lesion on MRI, and this was not visible by ultrasound, so we were planning to tag it with Lepiodol for ablation. On the DSA image in the middle here, you can see that there are a lot of vessels headed to this area of the liver, so it's hard to know, which one applying the tumor. Now, you could obviously select a whole bunch of these branches, but that's going to be time-consuming. And moreover, look at this cone beam CT over here. The lesion is clearly there, but it's only slightly more hyperenhancing than the surrounding normal liver parenchyma. So for that reason, I think you might never see this lesion by DSA alone, even if you were in the correct vessel. So, liver MRI is going to reveal tumors that you need to treat, but they may be incredibly difficult to see without the matching high level of tissue contrast afforded by cone beam CT. So here's another challenging case, and that is when you have a half moon sign oriented in the anterior posterior direction. So we can see this tumor is enhancing on the DSA, and in the AP projection, it looks like you're getting a nice, complete round tumor blush. However, cone beam CT is going to be your truth machine, and it shows you that you're treating exactly the posterior half of the tumor and missing the anterior half. You might say, I wouldn't be fooled by this because I do oblique DSAs in addition to, APs, but I would respond that cone beam CT is really the ultimate oblique. Now, parenthetically, I would note the difference in image quality between this cone beam CT here, which was done on one of our Philips units, compared with this prior case that I showed, the image quality here, which is really excellent. This was done on the GE unit. So like I said, I don't want to belabor the importance of cone beam too much because I doubt there's much disagreement about the importance of it. But I think the real issue is the practical aspects of cone beam CT. And so that's what I want to focus most of my time on. I think the key barriers to doing successful cone beam CT are performing these spins on large patients, imaging peripheral tumors, and concerns about prolonging the overall procedure time. And these practical issues become really important, so much so that they can prevent you from even being able to do cone beams at all. But what I want to show you in this presentation is that these barriers can be eliminated, and I would argue for all intents and purposes eliminated entirely with the key design improvements of the GE Discovery, which include a large radius C-arm, a large detector size giving a large field of view, and the ergonomic C-arm design that gives a really innovative rotation geometry. So we have some big patients in North Carolina, and on some of our prior cone beam CT systems, there have been patients that we simply could not perform spins on because of their size. Now, this patient here has a BMI of 50, and you can see that on his diagnostic CT scan, his subcutaneous fat is outside of the field of view on the diagnostic scanner. So this is a patient you might simply not be able to spin. And yet here I'm showing the cone beam CT that we successfully did on this patient using the GE Discovery. And this was possible because of the large radius of the C-arm. Now, you might say, I can do this case on my system by putting the patient's arms above his head and taping his belly in real tight. While that may be true, you can see from my base catheter and the descending thoracic aorta on the corner of the image here that I can do this case radial with the arms down, which is going to be a lot more pleasant for everyone involved in the case. So because of the large detector size, peripheral tumors are also going to be well within your field of view. Here's a patient with this small tumor in the periphery of the right lobe of the liver. He had disease elsewhere in his liver that I couldn't ablate. So while we were treating those other sites with Y90, I also wanted to simultaneously do a radiation segmentectomy of this particular tumor. We can see the feeding artery so well with this cone beam CT that, I think you can be really confident in this treatment plan. As you all know, radiation segmentectomy is a potentially curative treatment, and I think peripherally located tumors are especially well suited to this approach because you can be really selective and really aggressive with your dosimetry. But in order to achieve those curative outcomes, you have to be able to delineate the arterial anatomy all the way out to the periphery of the liver. So lastly, I mentioned case time, and this is probably the biggest barrier that I've faced in my practice. This slide shows a comparison of my Y90 radioembolization mapping cases over roughly the last year between the GE Discovery and one of our other units, which is a Philips Allura Clarity with open trajectory. So currently I average a little less than 3.5 spins per case with both systems. The difference is I average 43 minutes from access to closure on the GE Discovery versus about 67 minutes on the Philips. Now, there are a couple reasons for this. I think the primary one being the ergonomics of the spin on the GE, as I'm going to illustrate shortly. But I think in addition, I'd point out that the GE makes it really easy to do in-room image manipulation, which helps us work efficiently. Now, parenthetically, we also have an older Philips Allura system without open trajectory, but doing cone beam CTs on that system is really challenged. With that system, we are having to do things like tape bellies in tight and whatnot. And sometimes I simply cannot perform all the cone beams I want to on that system. I didn't include those data because, those cases really took forever and it's really not comparable to these modern cone beam CT systems. But I only mention that to say that if you are unfortunate enough to be relying on one of these older cone beam CT systems, then there really is a better way to do your cases. So what I want to illustrate here is where this case efficiency comes from. So our room setup is shown here. The nurse is positioned by the patient's right shoulder, and note the geometry of the C-arm. The C is offset to the left side of the source and detector. And this is really clever because it means that the sweep rotates around the leads and lines, which are running along this orange arrow towards the nurse's station. So therefore, there's no need to reposition the arms or to reposition support apparatus because the C-arm will rotate around them. And I also want to point out that this is true for intubated patients as well. I know we're talking about liver cases here, but a few days ago, I treated a COVID positive patient with rectal bleeding. The patient was really in extremis, intubated on pressors, on a massive transfusion protocol. And I didn't anticipate needing to use cone beam, so I didn't do anything special when we set the room up. Yet when I couldn't find the bleed with DSA alone, I was able to spin, identify the bleed with cone beam, and treat it so easily, despite all the support apparatus because of this design. So that segues into my last point about room setup, which is that I never do anything special or unusual in terms of patient positioning, even for my liver tumor cases where I know I'm going to be doing cone beam CT ahead of time. The C-arm design, the large radius of the C-arm with a large distance from the source to detector, the large detector size with the large field of view, they're just so forgiving in terms of patient size and patient positioning. And the other thing that I hope is apparent from this picture is that because the C-arm is offset to the left of the source and the detector, you can push the table in the cranial direction to easily allow for cone beam all the way down in the low pelvis, for example, for your prostate artery embolization cases. So, gone are the days of me having to supervise the patient's positioning on the table before the prep and drape, saying, hey, we've got to move the patient towards the head of the bed, or we've got to offset the patient so the liver is centered on the table, so I don't have to do that anymore to ensure successful cone beam CTs. So what about femoral axis versus radial axis? Well, I do distal radial axis in the anatomic snuff box for my cases, which means I have the left palm positioned on the patient's right hip. I leave the right arm down at the side for the whole case, which means I do cone beam CT with both arms down in this compact position. But since this working position obviously simulates a femoral artery axis, you could just as easily be doing this case femoral with the same setup. So some of my partners do femoral axis, and as I alluded to earlier, the offset of the C-arm relative to the source and the detector allows them to move the table all the way cranial to visualize the groin axis, as I'm showing here. I have other partners who do conventional radial axis. So for them, the C-arm translates to the left for their axis, and then they can adduct the left arm to the side for cone beam CT. Now, I'd also like to point out that parenthetically, this floor room is about 500 square feet. So you don't need an especially large room to accommodate all this motion and all this versatility for different operators in your practice who have different preferences for how they approach cases. So the last point I want to make is about image quality. I think the image quality of the GE Discovery is really superb. And in this example, you can see how clearly and distinctly you can see, the nth order branches within the liver. Obviously, minimizing patient motion is key. So I really coach patients up on breath holding and I avoid over sedating them. But there's also some nice motion freeze reconstruction software that can help you clean up images a little bit. The other thing I've mentioned a couple times throughout the talk is that I do all my spins with the arms down, which is really key to improving our efficiency during cases. But there's no trade-off in terms of this time efficiency and image quality. And the reason for that is that the GE has a dynamic exposure during the spin to ensure that there's no loss of image quality, even with the arms down compared to arms up imaging. So to summarize, we obviously owe it to our patients to provide the best possible outcomes, but also as far as our field goes, we have to be mindful of providing the highest quality care since there are emerging alternative treatment options for HCC. So SBRT, new anti-angiogenics, immunotherapy. And so to that end, I think that regular reliance on cone beam CT will help to improve your embolotherapy options. Now, unfortunately, there are some real-world hurdles to doing cone beam CT, but fortunately, the design improvements, that I've highlighted with the GE Discovery have really removed physical obstacles. So you can do cone beam CT quickly, reliably in patients of any size and from any access point. And finally, I think that the outstanding image quality can reduce your procedure time because you're going to be able to be quicker and more confident in identifying tumor feeders as well as non-target arteries. Thank you.
So I would like to thank the team at GE, the moderator, and my co-speakers for the opportunity to participate in the exciting webinar and review my experience with the Discovery Room as it pertains to embolotherapy. As you all are aware, goals or objectives of transarterial hepatic therapy are to maximize the treatment to the tumor while limiting the non-target treatment, and hopefully this will result in a successful local regional therapy. However, there are problems that do exist, and these include challenging anatomy or early stasis and reflux, and this could ultimately lead to increased procedure times, increased non-target embolization, and even an aborted treatment. So many of us, as you know, do a lot of high-quality imaging during the procedure, which we believe is critical to optimize tumor targeting. And in fact, we know that cone beam CT provides accurate spatial evaluation of the arterial supply and identifies potential tumor-feeding vessels. It's been shown that 3D angiography with cone beam CT or a combined multi-detector CT angiography does significantly improve survival rates after therapy. And we also know that cone beam CT adds information beyond DSA in about 60% of procedures and can actually impact the procedure in 19% of cases. And this was shown in a study that I was involved in at MD Anderson it was published back in 2007. We also know that cone beam CT with navigation software can more precisely identify tumor feeders, and this can significantly reduce the recurrence rate of targeted tumors when compared to DSA alone. And lastly, we know that immediate post-procedure non-contrast cone beam CT is important, as you have the opportunity to assess lipoidal or drug-eluting bead deposition and quantification within the targeted tumor, which can be predictive of local recurrence, and can also identify additional tumor feeders to be treated during the same or subsequent TACE sessions. So it's been shown in this paper back in 2012 that there's a statistically significant improvement in local progression-free survival, as well as overall survival, when cone beam CT is used for TACE than when cone beam CT is not used. So how can we treat patients such as this one with rectal carcinoid that's metastatic to the liver, who had multiple microwave ablations but now has an enlarging tumor within segment 8, who was referred for transarterial embolization? Well, with the GE equipment or software, we can use a program called Liver Assist, and this actually helps in the being able to determine unclear vascularity. So if you look at the patient here, you can see that there's a mass in segment 8 that when we look at the digital subtraction angiography, we really can't see it on the initial runs, but only later on at the end of the run can we even get a glimpse of it. And then this is also shown when we do cone beam CT here. The initial images don't show the actual tumor. So Liver Assist is a software program that draws a vascular map to the artery supplying the tumor. It's typically run by the technologist under the supervision of the IR performing the procedure, where no manual analysis of the cone beam CT is actually needed. The potential vessels are then highlighted for the subsequent embolotherapy. Importantly, there's an algorithm that automatically segments the vessels and removes the bones. The region of interest is then placed within the tumor, and the distal tip of the catheter is marked. And this allows the program to accurately highlight with high sensitivity the tumor feeding vessels. So with Vessel Assist, it is possible to export the embolization plan on top of the live fluoroscopy. It's also possible to move the table and gantry magnification, and the roadmap will then follow. That is, one can change the angulation at the table side to find the best obliquity for catheterization and the subsequent delivery of the therapy. So here we see on the immediate post-TACE cone beam CT that the tumor is effectively treated, and on the 1-month follow-up MR, there is no vascularity to the tumor, and the tumor is actually reduced in size. So if we look at the workflow summary for this shows the ease of workflow from obtaining the preoperative MR to the cone beam CT to the Liver Assist guidance software to the treatment with embolization, and then ultimately to the follow-up MR. And this is just a list of papers that highlights the use of Liver Assist over the years. In fact, these papers have shown a sensitivity to detect tumor supplying vessels from nearly 88% to 97%, that the number of DSA acquisitions can be reduced by 30%, and that the procedural time can be reduced by 10%. So another topic that often comes up is whether or not you can plan the vascular maps for multiple tumors simultaneously. This becomes very important during embolotherapy, since the administration of split doses might depend on the tumor burden or on your vascular map. In this case shown here of a patient with diffusely infiltrated disease who was treated with numerous prior interventional therapies, we can actually show that these tumor supplies can be easily mapped. And based on the Liver Assist software, the operator can export the segmented tumor-feeding vessels to fluoroscopy and proceed with the embolotherapy. And as you can see, we can now define the best catheter position to reach multiple tumors at a time and optimize the distribution of the embolic agent. So we can see here that there's different colors, one going to the tumor down below here, and this other one going to the tumor supplying the much more cranial tumor. To see the benefits of Liver Assist, you can choose the roadmap you need and the opacity of the vessels. And this will be highlighted right here where we see it, and then we can actually then use a digital zoom instead of using magnification, which then saves dose. The catheter position can then be easily assessed, and this can all be done at tableside. As mentioned earlier, we can define the best catheter position to target multiple lesions from a single catheter position while minimizing non-target embolization and help to better predict the amount of embolic to deliver on each target vessel. So at the end of the procedure, which you can see here, an area of liver was not treated, and this was seen very nicely on the 1-month follow-up MR. So what that begs the question is that one of the limitations from the literature is that Liver Assist cannot catch arterial tumor supply if the origin is more proximal to the injection point, or if it's extrahepatic and you'll never see it. So that's just one of the limitations from the literature. Automatic registration of the previous treatment completion cone beam CT is shown here with the current injected cone beam CT. This also confirms the supply from the inferior phrenic artery, and as you can see from the panel on the right, that Liver Assist shows that one vessel could be spared, and that is shown here, which is the diaphragmatic branch of the inferior phrenic artery. And then we can see the pre-treatment and post-treatment MRI showing excellent response after the therapy. So the software can also utilize cone beam CTs from previous sessions, like this case here, shown of a patient with fallopian tube cancer metastatic to the liver who presents for radioembolization. Here, the patient was found to have gastric uptake on the follow-up SPECT CT. So prior to the Y90 treatment, we were then able to use the previously obtained cone beam CT to assist in catheterizing the right gastric artery, which you see here, for embolization. And then for the subsequent catheterization, we can use the same map as well as for the therapy. So you can really reach your target vessels faster and save acquisition and radiation dose doing these types of imaging. So again, in terms of workflow summary, you can see the simple, straightforward workflow for using previously obtained cone beam CTs. So similar to the previous case, there's also the possibility of using the preoperative imaging, which can either be CT or MR for catheter guidance, like in this case of a patient with metastatic GI stromal tumor who has symptoms of abdominal pain, pressure, and early satiety, who presents for TACE for symptom control. Here we can plan the procedure using automated vessel and bone segmentation, which leverages the availability of preoperative imaging. The preparation of volume for fusion is performed by the IR technologists. For guidance, we obtained 2-view registration, which results in a 99% dose reduction when compared with cone beam CT registration. Importantly, the initial registration of volume can be done prior to draping the patient with no workflow interruption. And once registered, you can move the table and gantry and the whole roadmap will follow. So you can see that right here. So here you can see that the vessel assist can help facilitate celiac access by allowing the display of the preoperative CT as a volume rendering or using the contours only. You can position your catheter accurately, adjust the initial registration with the catheter or puff of contrast, and display the CT volume. See here, you can see the catheter right now without any contrast going right from the celiac axis into the tumoral vascular supply. Again, as a workflow summary, we can easily take the preoperative imaging, obtain 2-view registration, which also save radiation dose, and then easily facilitate catheter access without additional contrast injection. Well, what about using this software to develop new embolization strategies? And in this case, we're going to talk about balloon occlusion catheters for conventional TACE. So what I wanted to do is just show a proof of concept before we get into the actual case of using the liver assist. So here, there is a patient with a 3.5 centimeter liver metastases from urothelial cancer that's abutting the right posterior portal vein, making the location for thermal ablation very difficult. And as you can see on the right, the DSA shows a mildly hypervascular mass. So I was only able to catheterize one small arterial branch arising from the right hepatic artery, and bland embolization was performed. And as you can see, we got very early reflux, and there's no flow, at least from this perspective on the right, would flow into the tumor. So a few months later, the patient returned for another MR, which showed that the tumor was more enlarged. As performed earlier, there were no obviously selectable vessels. Therefore, I had the idea of using a dual balloon occlusion catheter in an attempt to isolate the mass's blood supply and preserve the remainder of the right liver parenchyma. So this is the catheter. I don't want to get necessarily into the name of the catheter, but I can say that we were able to use this catheter, and you can see where the plan is to place the balloons. There are numerous arteries supplying this mass, but not one that's really useful in terms of embolotherapy. Just as an FYI, this catheter is not manufactured by GE Healthcare. So we see on this cone beam CT, which is done with the balloons not inflated, that there is a lot of flow throughout the entire liver. However, the middle and right panels show the contrast with the balloons inflated with near complete isolation of the tumoral vasculature. After the procedure, the CT scan was performed, showing Lepidol within the mass, and then in 2 months, the MRI showed complete necrosis. It's interesting that in this patient with urothelial carcinoma metastases to the liver, which are not typically treated in this fashion, that we actually had a really great radiological outcome. So based on this successful treatment concept of the dual balloon occlusion catheter, which did not use liver assist, it has been shown in cases that I've now done that liver assist technology may be able to help. In this case, we have a 69-year-old man with bilobar large HCCs referred for TACE. The patient is not considered a transplant candidate. However, given the location of disease, he was considered a possible candidate for future resection since the central liver is really tumor-free. And we used liver assist to help find the feeding vessels. So as you can tell, it's important to define the proximal and distal balloon positions to optimize tumor coverage and preserve as much of the healthy liver as possible. And then we can opt to choose where we want to place the balloons. So the patient had already had embolization of the mass in the right lobe, okay? And now we want to place a catheter in an area where we can now treat the tumor in the left lobe. So if we look, you can see the markers of the balloon here and here, and we can follow it back to where we can actually isolate where we want to treat. Okay, so the balloons are in position according to the liver assist protocol. And then we can now do a DSA to show that we were able to accurately handle the tumoral blood supply. And this is just an axial and coronal cone beam CT showing successful tumor targeting, which you see here and here. And then we can now see from the pre-MRI on the left that the post-embolization MR now shows no tumoral enhancement. So this was really considered an excellent response. So it's interesting that in this patient, we were able to take this patient who was really outside of Milan criteria, outside transplant criteria, and actually get this patient to the transplant list. Now, I'm not saying that he was subsequently transplanted, but these are just strategies that we can use to be able to take patients and if the patient was to be a resection candidate, get this patient to successful surgery. Now, lastly, I wanted to mention what we now call virtual injection. Now, we know that we have a lot of knowledge of tumor-feeding vessels, which alone may be insufficient when trying to determine the ideal final microcatheter position for safe and effective treatment delivery. As we said earlier, the goal is to optimize tumor therapy while minimizing non-target embolization. And this usually requires, despite the fact that we do all these cone beam CTs and this liver assist, the use of manual microcatheter-based interrogation of suspected tumor-feeding vessels. This, therefore, can often be time-intensive, leading to increased fluoroscopy times, radiation dose, contrast volume, and because we're using catheters and wires, there is a risk for vascular injury, which then could possibly injure or spasm the arteries such that the ultimate therapy can't be done. So it would be really nice if we were able to predetermine an ideal microcatheter position using what we would consider or call virtual interrogation software that could tell us where we need to go without having to actually catheterize the vessels. And this could lead to reduced fluoroscopy times, radiation dose, contrast volume, and again, the risk for vascular injury. So we can use intraprocedural cone beam CT data that's then reconstructed and loaded with virtual injection software. And what this does is that the vessels are semi-automatically segmented after the user defines the proximal origin of the feeding vessel for the tumor. And then targets are then defined in cross-sectional views from available pre-procedural MRIs registered to the cone beam CT. And then all the vessels that appear to supply the tumor would be automatically identified. So how does this virtual injection work? Well, it's really the mouse pointer that we're using, which acts as a dynamic virtual microcatheter tip. All vessels distal to the cursor position are now highlighted instantly, and therefore we can mimic the injection from this point distally. Now, using the simulator property, the software identified and other suspected feeding vessels are virtually interrogated, not manually interrogated. And then once all feeding vessels are confirmed, we can then utilize this for accurate predetermination of the microcatheter positioning to maximize the treatment delivery and decrease non-target embolization. And therefore, we can take these volume rendered reconstruction models of the tumors, feeding vessels, and virtual injection point that are created, and then this can be used as an overlay onto live fluoroscopy to guide the procedure for final microcatheter positioning. So this is a case that highlights the use of virtual injection, and we actually published this as a letter to the editor last year. This is a case of a 55-year-old man with a 3.6 centimeter segment 7 HCC who now presents for TACE, and we can see the tumor here in segment 7. There's multiple vessels that may be supplying the tumor. It's kind of unclear. So we do the virtual injection, which will be shown in this video. So the mouse cursor behaves as the virtual microcatheter tip and allows selection of any point along the 3D vascular map. And this outlines the perfused territory on the axial and coronal cone beam CTs. The perfused outlines can then be reviewed by scrolling through the cone beam CT reconstructions and confirm the tumoral supply. The virtual microcatheter tip can then be moved to any point along the 3D vascular map to examine a more selective approach. And then we can repeat the review of the axial and coronal cone beam CT reconstructions, as you see here. The virtual microcatheter tip can then be pulled back to a less selected position, and then we can repeat the review of the axial and coronal cone beam CT reconstructions. The site was then determined to be the ideal location for the treatment delivery that then optimizes the tumor treatment and minimizes non-target embolization. So here we see that, again, in more detail, but at the end of the day, we can then see that we were able to successfully treat the tumor using the virtual injection algorithm. Now, ultimately, this may be able to allow us to accurately predict the treatment distribution based on what we consider the preferred microcatheter tip position where the mouse is placed, and ultimately can allow the operator to virtually identify the tumor or non-tumor supplying vessels without having to manually advance any catheter, which, as we said, can result in injury and some other issues. So in conclusion, I hope to have shown that liver and vessel assist can help with targeting of liver tumors and can result in high sensitivity to detect tumor supplying vessels that can then increase the predictability of therapy and our confidence that we actually got an effective tumor therapy. If needed, we can use this software to help divide the dose when multiple tumors are present. And I believe that by using all these different strategies, whether it be using double balloon occlusion catheters, whether it be better tumor targeting, whether we're able to use newer and effective embolotherapy strategies, ultimately the goal is to reduce procedure time, contrast, radiation dosage, and like I said earlier, potential injury to the vasculature. So with that, I'll conclude here. And I want to thank GE and the other speakers and my moderator for allowing me to give this presentation. Thank you.
Good evening. Tonight I'm going to talk about the advanced imaging integration within the interventional suite. And specifically what I'm talking about here is fusion with ultrasound, some of the technologies available for needle guidance and ablation guidance, and how you can incorporate ultrasound fusion with the needle positioning software available on the GE system to more effectively place your needles and your probes where you need to do ablations and other minimally invasive procedures in the IR suite. These are my disclosures. I'm on the advisory board for several companies, including Siemens and several small medical companies, and I have some speaking arrangements with GE, Medtronic, and Gurbet, and specifically this talk is a GE sponsored talk. So I'm only going to talk about technologies that are available through the GE systems tonight. So first we're going to talk about ultrasound fusion, and this is some examples of two images that you can see with ultrasound fusion, and what you get is a CT scan that's preloaded into the software of the ultrasound machine that's correlated with an ultrasound image that's obtained real time, and it gives you the CT information that shows where the tumor is and where the portal veins are, and then in this image where the portal vein access points are, so that you can gain access to your targets as easily as possible and correlate that information with your pre-procedure imaging. So how does it work? So what we do when we're trying to put these fusion images together is we start with a pre-procedure imaging study, like a CAT scan, an MRI, a PET scan, and we import that into the GE Discovery system and its advanced workstation. And then what we can do is do a non-contrast cone beam CT acquisition with this patient tracker on, and I'll show you a bigger picture of this for reference. And if you wanted to, you could do a cone beam CT with contrast in order to opacify a mass, particularly if you're going to do a combination intra-arterial therapy plus ablation procedure, it allows you to do both procedures in the angio room together and use your cone beam CTs that you obtain for your embolization as part of your targeting for your ablation to follow. And then we automatically fuse our preoperative image to the live ultrasound using this non-contrast cone beam CT as a bridge between the two studies. And you get an image like this where you can see the mass here, but you may have a hard time seeing the mass on the ultrasound. Any misregistrations during this case can be corrected with a couple of clicks by adding some common landmarks on both the ultrasound and the fused volume. And that helps you get a really perfect alignment between your ultrasound image and your pre-procedural imaging study that you're using for targeting. So this is those non-enhanced cone beam CT images we were talking about. This is the fiducial marker that's taped to the patient's skin. It's got a couple of markers that can be identified on the cone beam CT like this, and then it attaches to the top to a probe that connects through its magnetic tracking system to know where in the position of the body all the other elements are. Notably, the ultrasound probe has a connection to the system. And then there's a needle guidance probe that either clips on the back of the needle, or they have a small fiber that will fit down a guiding cannula. So we've created some guiding cannulas that will accept our ablation probes that are of exact lengths for the guiding probe, and then you can place that in, exactly localize the tip of your needle and where the tip of it will go. And when your probe goes in, it goes in 2 centimeters beyond and allows a 2 centimeter burn, or it can go in 4 centimeters beyond and allow a 4 centimeter burn. One of the things you want to make sure is that you see the tracker on the cone beam CT. This was to see all 4 points. The newer systems really only require that you see these 3, and then you can look at that. And then this is sort of the fusion of the mass with the ultrasound, and then you can readjust it. If you don't like this mass here, you could go and find the kidney and find a point in the kidney on both the ultrasound and the CT scan, and that will update the registration for you. If you didn't have any of the pre-procedure imaging and the tumor was visible on ultrasound, you can actually just fuse your ultrasound with the pre-procedure CT if you want to. And then again, if you can see it with ultrasound, you may not actually use the additional pre-procedural imaging as your guide. This is our setup in the room. We have our discovery system at the head so it can do cone beams. The ultrasound sits over here, and the screen actually doesn't need to face the operator because it can be displayed up here on the large display. And then you have this very small magnetic receiver that fits over the patient. Moving this C-arm in and out is possible during the procedure. We can move it out when we're using the active tracker for needle placement, and then we can bring it into fluoro over our area, or do a cone beam CT for confirmation, or do the needle guidance updates, which I'll show you in a little bit. So this is a case that I'll discuss as an example. This is a patient with a little bit of ascites, and there's a central mass in the MRI, on the CT and the MRI, and you can see it there. We actually did lapidol enhancement to this mass to help assist with targeting, and you can see what the mass looks like on the cone beam CT after it's reconstructed. And then you can actually fuse that using this active tracker software, and then you can confirm by putting flow on it and see the flow around the mass. You can see the mass here, you can see the mass here, and this is ultrasound contrast versus the cone beam CT contrast and ensuring excellent fusion. So this is ultrasound tracking, and you can see what we can see here is the graphics that you identify when you are looking at the ablation unit going in. And what you saw there was 2 different approaches. I'm going to take this static view here for the purposes of, you can see this blue line here, and then it turns green, and this is where the tip of this needle is at this point in time. And our target is to place our needle beyond the tumor there. And you can see on ultrasound, I don't really see the tumor quite so well. Both the blue and the orange are out of plane, and the green is in plane. So the goal is to get this green dot exactly where we want it to be. So if I were to replay the system, you can see this is an attempt at getting into the area, and we were able to get our green dot right down there past it. And then this was just another view of the mass as we sort of looked at it from a different obliquity to sort of see what we're looking at. So once the needle is placed, we can do another cone beam CT for confirmation, and since there's lapidol in the mass, we can see where it's located. What you see down here is the software that comes with the Medtronic probe that is used for ablation planning. You can see the zone of ablation in red encompassing the tumor. This zone of ablation is known for the Medtronic probe and is able to be programmed into the ultrasound, so you can get the same zone right on your ultrasound, and it overlays on your CT as well. So you can turn this on or off. This can be manually programmed in for any of the ablation devices that are out there, as long as you know what the device is and what its predicted zone of ablation is. That's what the graphic will represent on the ultrasound machine. And it gives you the ability to say, this is an area that I intend to ablate, this is what I'm likely to ablate. And you can use your experience to justify that how much you trust this, but it is one of the things that allows you to really look at, is my needle in the right place, or do I need another needle? And then at the end, we'll do a contrast enhanced cone beam to look at the ablation zone. And this is an example of an ablation zone around that tumor that you've got complete ablation of that tumor. So now we'll update this with our needle guidance software. And this is an example of a patient video here. This is a patient with multiple tumors in the liver. And this is this needle being placed into this particular tumor. You can see this is in plane, green all the way, with the probe being placed right here. And this was a active tracker with the fiber all the way down the cannula. So we were able to place the cannula down right to it and get it in the right position. And how do we do that? So first we use our pre-procedure imaging, and this is a PET scan that demonstrates the masses going through. And we target these by looking at the 3D volume of this fused with the cone beam CT that we did without contrast. And we're able to place these targets on the PET scan as where we would like our needles to go. That way, when we place our needles with ultrasound, everything's fused in the system the way we just described it, and then we're able to confirm our location. In this particular treatment, in this patient, we intended to treat several of these peripheral nodules down here, and you can see this is the targeting of the last probe of these 6 probes, and that would be this needle right here. And what we did in this particular system is we were able to do 2 orthogonal fluoroscopic views and then draw the active zones of the cryoablation probes that we used with I think it was the Galil system in this case. And actually, no, it was the cryo probes from the other company. We had both, and they get confusing sometimes. So we were able to draw the active zones of these cryoablation probes, and this was the needle we intended to place, and this was our planned targeting approach on the workstation. And by overlaying this, we're actually able to update this without doing another cone beam CT. And the way this works is it uses the geometry in these 2 orthogonal views, and it tells you that it's able to reconstruct the volume based upon those 2 samplings of data. You'll get an image like this where you've drawn these lines, and these are probes that were placed along those green lines and the lines of the probes that were there. And this is the target line looking down the barrel using the cryoprobe, and this is the following the line all the way down. And we actually placed this, I'll go back. We placed this is the clip on the back of the probe with the wire that lets us detect where the tip of the needle is going to be on ultrasound. And then by placing it there, we're able to confirm that that needle is in the right location. Next topic I'm going to look at is some of the ablation targeting techniques that we've used. This is a patient with some Lipiodol injected into this mass posteriorly. What we do is we will selectively catheterize, and we'll use the vascular mapping software on the cone beam CT to map out which vessel to select to place our Lipiodol, and we'll use the overlay to follow our tract all the way up. We inject the Lipiodol and we enhance the mass, and you can see the mass over here on the cone beam CT, and this is the mass on the pre-procedure imaging on the MRI, and this is the mass on ultrasound. Not much of a mass is seen, but these zones overlay each other, and you can do the ablation there. So here's an example of the fluoro that's done with the needle in the probe, and if you take a close look here, you will see the slightly dark enhancement around the tip of the needle, which just by observing under fluoro, you can see the enhanced mass and the cryoprobe right in it. Here is scanning through the area with the cryoprobe in place and the tip and it identified, and it shows us where the ablation zones are, where the needle zone is, and this is where our two positions of the potential needles, and we actually repositioned to get better central location on this mass so that we had a more effective ablation in this particular patient. And you can see this is the probe on cone beam CT right by the mass. That's after repositioning, and we were able to get a zone of ablation that was going to completely encompass the Lepidol enhanced mass. So in summary, Ultrasound Fusion helps place the needles in real time. Stereo 3D can help us update our probes with confidence to know that we can go get our needle where we need to go without having to do subsequent cone beam CTs. And this is an image I show here of a cone beam CT of a cryoablation, post-cryoablation. And you can definitely see the ice here on these post-cryo cone beam CTs. And this will help you confirm that you're getting an effective ablation, particularly when you fuse your cone beam CT to your pre-procedure imaging. Thank you very much.
Thank you, we appreciate it. And for the three physicians, there we go. If you guys don't mind opening up your webcams, we'll field some questions here from the audience. There we go. Great, yep, so thank you first for sharing your practice and incredible use of technology in order to improve outcomes with us. Incredible examples of putting technology to work in a really meaningful way to increase access for your patients and increase your accuracy, your confidence, and ultimately seeing some pretty incredible clinical results. We have a couple questions that have come in, so I'll try to move through those. Dr. Ronald, from your presentation, there was a question about with the ability to get a cone beam CT so reliably and routinely now, are there any cases that you can think of you've taken on or you've thought of differently in how you approach therapy versus how you would have previously?
Yeah, that's a good question. I mean, I think that we're finding more applications. You know, one of the things we're starting to do more and more is using cone beam CT for GI bleeding cases. You know, when we don't see a GI bleed on DSA, you know, we used to think, well, maybe it's stopped or maybe it's too slow for us to see. But with the improved tissue contrast from cone beam CT, we've found that we can detect more GI bleeds by seeing, you know, a small amount of contrast in the bowel lumen and mapping out all the arteries. And, you know, one of the things that's made that feasible is just how easy it is to spin. I mean, a lot of these patients are, they have a lot of support apparatus, like I mentioned. And that used to be a big impediment to doing advanced imaging on those patients, but it's no longer the case. And so it makes it very feasible to do those cases. And I think we do fewer negative arteriograms for GI bleeding as a result now.
Nice, thank you for sharing that. I guess for the other two physicians, any follow-up thoughts, any cases that you can think of maybe you've taken on or thought of differently by the ability to use cone beam CT so easily?
Well, I'll just say that in my practice, I use cone beam CT to essentially substitute for a CT scanner because I don't have ready access to the CT scanner. So a lot of the complex combinations of vascular and ablation techniques that we use in a variety of unusual situations, such as bones and soft tissue, those can be augmented by the use of cone beam CT, being able to map out your vasculature and select the vessels that you want to select. It's similar to GI bleeding. It's also useful in the bronchioles when you're trying to find the various sources of bleeding, particularly in the upper lobes.
Mm-hmm.
Yeah, so to add to that, I mean, I definitely agree that I do every case with cone beam CT in terms of liver, and we definitely do cases of GI bleeds, especially those that are very difficult to see, because that actually, I mean, this is not FDA approved for this indication, so, but that we do that. One thing I did want to bring up, and James had alluded to that briefly, but not in the same fashion, is the whole idea of being able with the GE system to do cone beam CTs with the arms down. Because basically, when you use other vendors, you seem to always have to, in order to reduce the streak artifact, at least for liver cases, we always have to put the arms up. And it makes the procedure much more complicated, much more difficult for the techs and nurses. And it often allows one to decide or be talked out of actually doing that cone beam CT. So with this software, with this algorithm that subtracts out the bones and the ability to leave the patient's arms at their side rather than over their head, it just makes the whole workflow so much better. So I just wanted to make sure that was not overlooked, because when I tell people about this, they actually are they get very, very interested.
Yeah, understandably so. Thank you. Appreciate that. Dr. McLennan, a question that leans a little bit to what you were just discussing about access to a CT or using cone beam CT in lieu of a CT. So for the Fusion needle guidance software, it's a two-part question. First was, are you pulling cases from CT to angio? And second is, if so, what benefits has that provided you as an organization? Either operationally, does it make you more efficient, financially? And then how does this compare to your CT ablations? There's a couple things in there for you.
All right, so I don't have ready access to a CAT scanner on my schedule in my institution. So it's a CT's in a different department with a different schedule. We've got Wednesday mornings where we do kidneys, but that's only recently. So I used cone beam CT for the last 10 years to overcome my lack of access to a CAT scanner. So and so that's a unique issue related to our practice. And that being said, what I find is that having been forced to use the planning software in the Fusion with ultrasound, when I go over to CT to do an ablation procedure, the advantages of the fast acquisitions and the multiple acquisitions and being able to use CT fluoro are there, but some of the sort of active approaches to planning the software and planning your approaches and actually having some of the graphical representations just don't exist in the software packages for the CAT scans. And so one of my best tools is to actually bring the ultrasound machine over into the CAT scanner sometimes when I have to do a complex case over there, because I can use that Ultrasound Fusion system on a regular CT scanner also, and then use the CT scan to confirm needle location, perhaps give contrast during the ablation instead of just the end of the ablation, and demonstrate that my needle is accurately placed. It will limit the number of times you have to do spins or acquire CT images in a CAT scanner if you use the Ultrasound Fusion imaging, because you will place your needle with registration to a pre-procedure imaging study real time. It's a little bit like having the ability to place the needle into a PET positive lesion with real-time imaging of the entire volume of the PET scan. And then if you're in a CAT scanner doing an ablation, you can do a post-procedure, post-ablation.
Sure, yeah.
My phone's acting up, so Siri decided to join the conversation. Sorry about that. So you can do your acquisition of your CAT scanner, your cone beam CT at the end of the case after the needle's placed and after the ablation is started, and then that confirms your ablation zone is completely ablated. So
thank you, appreciate that. I just noticed time flies. We're already a little bit over, so I'm just going to ask one more question. I think will benefit the larger audience that came here. So Dr. Madoff, you mentioned that your techs drive the software. I think you mentioned it 2 different times, one with planning and then I think one with intra-procedure use of some of the software. Can you discuss the learning curve for your staff or how you divvied up responsibilities within your team?
Well, that's a great question. So, like many institutions, we all have super users, ones that are really able to learn the software programs, get trained specifically on the technology. I think that the technologists are very open to learning these really interesting things, and they see the real success of how these cases are done. I think that there definitely is a learning curve. I mean, I don't want to say that there's not, but to have, GE engineers come in and show the technologists how to really do all the applications, I think is pretty important.
Mm-hmm. Yeah, thank you. I guess anyone else, I don't know if the other two physicians had any thoughts on, like, Dr. Ronald, I know your installation of some of the software is relatively fresh. What your experience has been as far as just adopting some of the new technology, not only for you, but your staff as well, how you guys have approached that.
Yeah, I think we're still learning, and the software is really tremendously powerful, and there is a lot to learn there. But we have some super users, and the support from the GE staff has been great in terms of helping ramp up our use of some of these advanced applications.
Good. Thank you.
So I would just comment for anybody on the call that is in a smaller place or a place with fewer resources than the Cleveland Clinic, Duke, or Yale, that I think it's really critically important that the physician drives this learning curve, because what you need to get is a buy-in from your technologists that using the technology is what makes you great within your institution. When I came to the clinic 10 years ago, I made it a point to be able to know how to operate all of the cone beam CT technologies in all the rooms, so that I was not allowing the technologists to tell me that this was too difficult to do. And I would just set it up myself and run the spin myself. And when you're doing that, then the incentive is, well, this is something I ought to be doing to assist my physician. And when you have new technologists come in, sure, you'll get your more seasoned technologists to train them. But when you're working with the younger technologists who have just started, and you show them how to do these acquisitions or how to do some ultrasound fusion, it generates a lot of excitement that the physician is actually taking the time to show them how to do it. And what it will result in is a really dedicated staff that will help you be more effective day in and day out. And so you really do need to take the time up front to learn how to use it well, and then transfer that knowledge to your staff.
Thank you. That's really good advice. Yeah, agreement all around on that one. There's a few questions remaining, but I'll be sensitive to the fact that we not only are nearing the end of our time, but we're past the end of our time. So we'll ensure that we get answers to those for you in follow-up. And if you have any questions or would like any direct follow-up, oh, thanks. There's my email address. You can always feel free to contact me directly in the bottom right, sarah.lewis@ge.com. Thank you again to the expert panel this evening. You gentlemen were wonderful. We appreciate you sharing some truly incredible use of technology and really interesting cases, and just overall insights with the audience. And thank you to all of you that took your time this evening to be with us and join us. Thank you and good evening.
Thanks, Sarah.
Thanks.
Thanks, Sarah.